Okay, let's unpack this. We are diving headfirst into really one of the most urgent topics in acute care, the critical care of shock. And this isn't just about, low blood pressure.
Mm.
Shock is. It's the body's entire system failing to meet cellular needs. A whole body emergency when oxygenation and tissue perfusion just fall short.
It really is the ultimate life-threatening emergency, and understanding that minute-by-minute progression, well, it can be the difference between turning things around and catastrophe. Our whole discussion today, everything we're covering, it comes straight from a specific chapter focused on the critical care of shock in medical surgical nursing.
Right. So our mission today is pretty laser focused. We want to pull out those critical need-to-know concepts, really emphasize the why behind the symptoms you see, and zoom in on the key nursing priority concepts, the things that guide immediate action.
Exactly. And those priorities shape everything we'll talk about. We're basically looking at two main pathways to shock today. First, there's the failure of adequate perfusion. We'll use hypovolemic shock as our main example there. And second, we'll look at the systemic breakdown caused by infection using sepsis and septic shock. So maybe let's start with the absolute basics.
Yeah, definitely. What exactly is shock, like down at the cellular level?
Okay, so at its core, shock is this syndrome of widespread abnormal cellular metabolism. It happens because there's not enough gas exchange and tissue perfusion. So the cells, they get starved of oxygen, that's hypoxia. And when cells can't get oxygen, they switch to anaerobic metabolism. This creates a ton of waste products, they start dysfunctioning, they start dying, and that leads to organ failure.
And getting that oxygenated blood where it needs to go, that perfusion piece that's fundamentally tied to the mean arterial pressure, the MAP, that's like the driving force, isn't it?
Absolutely. Think of MAP as the pressure needed in the system to keep blood flowing into all those vital organs. And MAP itself is influenced by three main things. The first two are pretty direct relationships. Your total blood volume, obviously, less volume means lower MAP. And your cardiac output, how much blood the heart is actually pumping out each minute. More output, higher MAP.
Okay, simple enough. And the third factor is where the body gets a bit more dynamic, I guess. The size and integrity of the vascular bed.
Exactly right. And this one is an inverse relationship. So imagine your blood vessels suddenly dilate wide open, maybe from a spinal cord injury or a massive infection. The pipes get huge, right? So the pressure inside drops dramatically. Your MAP falls, even if your total blood volume hasn't changed at all.
Right. So how does the body react immediately? Like if MAP suddenly drops, what's the very first system that jumps in even before the hormones get going?
Good question. That's the sympathetic nervous system kicking into gear. Our blood vessels, normally they have a certain level of partial constriction. We call that sympathetic tone. When the body senses that MAP drop, it ramps up sympathetic stimulation. It tries to clamp down those vessels even harder, raise the overall pressure, and shunt blood towards the vital organs, like the brain and heart. It's the first line of defense.
Makes sense. Okay, before we get into the stages of how this whole thing progresses, maybe quickly list the four main types of shock based on what's actually going wrong functionally.
Sure. They generally fall into four main buckets. First is hypovolemic shock. That's purely about loss of circulating volume, think hemorrhage or severe dehydration. Second, cardiogenic shock. Here, the pump itself, the heart, is failing, usually after a big heart attack and MI. Third is obstructive shock. Something outside the heart is blocking it from filling properly or contracting effectively, like cardiac tamponade, fluid squeezing the heart. And fourth is distributive shock. In this case, the volume might actually be okay, but it's in the wrong place because the vessels are massively dilated or leaky. This category includes septic shock, anaphylactic shock, and neurogenic shock.
Okay, here's where it gets really interesting. Because it seems like no matter which of those buckets the cause falls into, whether it's blood loss or pump failure or a massive infection shock, tends to follow this predictable and really dangerous sequence. 4 stages. If we don't fix it, it really is a syndrome.
Absolutely. And recognizing which stage the patient is in, well, that's crucial. It determines whether the situation is reversible or if permanent damage is setting in.
So let's walk through them. Stage 1, the initial stage.
Yeah.
You said this one is almost invisible.
Pretty much. The key thing physiologically is that the baseline MAP dips just slightly, usually less than 10 millimeter Hg. Critically, the vital organs are still getting enough blood flow. Compensation is starting, but it's subtle. You might see some mild vasoconstriction, maybe a very slight increase in heart rate.
Which means it's really easy to miss.
Dangerously easy. And the source material gives a really important safety alert here. An increased heart rate and respiratory rate, or maybe just a tiny bump in the diastolic blood pressure. That might be the only sign in this initial stage.
So you really have to be watching for those subtle, persistent trends, not just one reading.
Exactly.
Okay, moving on to stage 2. The compensatory stage. Now the MAP has dropped more noticeably, maybe 10 to 15 millimeter Hg down. The heart's initial response isn't quite cutting it, so the body calls in the reinforcements, the kidneys, and the hormonal system.
Right, this is where chemical compensation really kicks into high gear. The body starts pumping out renin, ADH, aldosterone.
The big guns.
Yeah, and those powerful catecholamines, epinephrine and norepinephrine, all these chemicals are essentially doing one main job. Clamp down hard on blood vessels and make the kidneys hold on to every single drop of fluid to keep that central volume up.
And what does that look like at the bedside? What would you, the nurse, actually see?
Clinically, you're going to see things like thirst, the body screaming for volume, anxiety, restlessness, the brain's noticing something's off. You'll definitely see tachycardia, a faster heart rate as it tries to compensate, and importantly, narrowing pulse pressure.
Explain that narrowing pulse pressure again. Why does that happen?
So because of that intense sympathetic squeeze from the catecholamines, the diastolic pressure, the bottom number, starts to rise. But the systolic pressure, the top number, might be holding steady for a while. So the gap between the systolic and diastolic numbers gets smaller. That narrowing is a really key clinical sign that compensation is working overtime.
Okay, got it. And you'll also see decreased urine output, right?
Yeah.
Because the body's shunting blood away from the kidneys.
Precisely. Prioritizing brain and heart. Non-vital organs like the skin and GI tract start becoming hypoxic. The patient might have cool extremities.
But the good news here, in stage 2.
The good news is the patient can actually stay in this stage for hours. And critically, the effects are still reversible if we intervene appropriately and quickly.
Okay, but if we don't intervene, or we don't recognize it, we slide into stage 3, the progressive stage. This sounds bad.
It is bad. Now we're talking a sustained MAP decrease of more than 20 millimeter Hg from baseline. The body's compensatory mechanisms are starting to fail. They just can't keep up. And now it's not just the non-vital organs suffering. The vital organs, brain, heart, kidneys, are becoming severely hypoxic. The non-vital organs might be becoming anoxic, basically no oxygen, and ischemic.
So what are the signs now? They must be much more obvious.
Much more dramatic. Objectively, you'll see marked confusion, maybe lethargy. The pulse becomes rapid, but very weak, thready. The skin often looks pale, maybe even cyanotic, especially around the mouth or nail beds. Urine output might stop completely in urea. And the labs confirm a metabolic crisis. The blood pH drops low, acidosis, lactate levels shoot up because of all that anaerobic metabolism, and potassium levels rise as cells break down.
And subjectively, this is where that feeling of impending doom comes in.
Yes, and it's so important not to dismiss that. When a patient expresses that feeling, it's often not just anxiety. It can be a direct physiological consequence of the brain not getting enough oxygen. It's a huge red flag.
So stage 3 is basically a code red situation.
Absolutely. All hands on deck. The sources emphasize this is a life-threatening emergency. Interventions must happen within 1 hour of recognizing this stage to have a chance of reversing the effects before it triggers MODS, Multiple Organ Dysfunction Syndrome.
Which leads us, unfortunately, to stage 4, the refractory stage. Refractory meaning it won't respond.
Exactly. It's irreversible. At this point, there's been too much cell death. The vital organs have suffered extensive permanent damage. MODS is fully established, creating this vicious cycle where dying cells release toxins, triggering more microthrombi formation, causing more cell death. Therapy just doesn't work anymore.
And clinically?
You see a rapid loss of consciousness, coma. You might not even be able to feel a pulse. Respirations become slow, shallow, maybe gasping. Oxygen saturation is unmeasurable. It's the end stage, unfortunately. Recovery isn't possible.
Wow. Okay, that sequence is stark. Let's try to ground this now with our first exemplar, hypovolemic shock. This seems like the most straightforward type, maybe. It's all about volume loss causing perfusion failure.
In essence, yes. It results purely from losing too much vascular volume. That could be whole blood, like in a hemorrhage, or it could be plasma volume from something like severe dehydration, burns, or persistent vomiting and diarrhea.
So the risk factors are pretty clear. Trauma, major surgery, maybe GI ulcers bleeding internally, clotting disorders like hemophilia, or even liver disease, which affects clotting factor production.
Right, and also things like prolonged severe vomiting or diarrhea. And we shouldn't forget certain drugs, things like aspirin or NSAIDs that increase bleeding risk, or diuretics that can cause significant fluid loss.
Okay, so assessment. Recognizing the cues for hypovolemic shock. What are the absolute priorities?
Cardiovascular signs are front and center, and the sources are really emphatic about this. Increased heart rate is often the first sign of shock, not waiting for the systolic blood pressure to drop.
Why is that distinction so vital? Is it because the body's compensation that squeezing of vessels holds the blood pressure up for a while?
Precisely. That sympathetic response is incredibly effective initially at maintaining systolic BP. So if you wait until the systolic number actually falls, you're likely already well into the compensatory stage, maybe even tipping into progressive. By monitoring the heart rate trend, even a slight but persistent increase, you have a much better chance of catching it earlier when it's more easily reversible. Look at the pulse quality too. Is it becoming weaker, thready? Peripheral pulses might become difficult to find.
And we already mentioned the narrowing pulse pressure in the compensatory stage. That's key here too.
Absolutely. Rising diastolic, steady or slightly falling systolic.
Okay, cardiovascular.
What about the kidneys?
Super important. Decreased urine output. The guideline is usually less than 30 millimoles per hour or less than 0.5 millimolar per kilogram per hour is a very sensitive early indicator. The kidneys aren't getting perfused, the body's holding on to fluid.
And CNS signs. We mentioned restlessness, anxiety earlier. Thirst.
Thirst is a big one, driven by the volume deficit. The restlessness and anxiety can progress to confusion as cerebral perfusion decreases. And skin changes. Cool. Clammy.
Definitely. Cool or even cold skin, often moist or clammy. Pallor paleness is common. In patients with darker skin, you really need to check the oral mucous membranes for pallor. As it worsens, you might see mottling, sort of a patchy, purplish discoloration. Capillary refill time will be slow or even absent.
Okay. What about labs? How do they help confirm hypovolemic shock and maybe tell us the cause?
Well, regardless of the cause, you're going to see evidence of anaerobic metabolism. So low blood pH indicating acidosis, maybe high PaCO2 if they're not breathing effectively, low PO2, and definitely high lactate levels. Lactate is the key marker for tissue hypoxia.
Right. But the hematocrit and hemoglobin H&H levels, they can be tricky, can't they? Depending on why the volume is low.
Exactly. This trips people up sometimes. If the shock is caused by hemorrhage, active bleeding, then yes, you'd expect the H&H to be low or dropping as red blood cells are lost.
But if it's dehydration, like they just haven't had fluids or lost a lot through vomiting.
Then, counterintuitively, the HT and HGB are often increased. Why? Because the fluid portion of the blood, the plasma, is depleted. So the remaining red blood cells become more concentrated. It's called hemoconcentration.
So high H&H suggests dehydration or fluid shift. Low H&H suggests hemorrhage. That's a really important distinction for treatment.
Vital. Okay, so interventions. What are the immediate life-saving priorities for hypervolemic shock?
First things first, airway. Ensure it's patent. Start oxygen. Then breathing. Assess the respiratory effort. Then circulation.
For circulation, you need IV access immediately. Insert at least one, preferably two, large-bore IV catheters, 16 or 18 gauge if possible. You need to be able to push fluids fast.
And if there's obvious external bleeding.
Apply direct pressure immediately. Stop the loss.
What about positioning?
The classic position is to elevate the patient's feet, maybe 12 inches or so, keeping their head flat or only slightly elevated, no more than 30 degrees. This encourages venous return from the legs to the core. Avoid Trendelenburg, though, that can hinder breathing.
Then comes the fluid resuscitation. What are we giving?
Primarily crystalloids. These are solutions like normal saline, 0.9% ACL, or Ringer's lactate. They expand intravascular volume quickly. We might also use colloids like albumin or blood products, packed red blood cells, plasma, platelets, especially if the cause is hemorrhage or there's significant protein loss.
Okay, and speaking of blood products, there's a crucial safety alert about infusing them, isn't there? Something about Ringer's lactate.
Yes, this is critical. You must only use normal saline to infuse with blood products, never Ringer's lactate.
Why not?
Ringer's lactate contains calcium. The blood products are preserved with citrate, which binds calcium. If you mix RL in blood, the calcium in the RL will overcome the citrate and cause the blood to clot right there in the IV tubing or even in the patient's vein.
Wow. Okay, so NS only with blood. Got it. What about drug therapy? Is that common in hypovolemic shock?
It's usually secondary. The primary treatment is always volume replacement. But if fluids alone aren't enough to restore MAP, then drug therapy might be added. These drugs usually aim to increase venous return by constricting vessels or improve the heart's contractility. Things like dopamine, norepinephrine, vasopressin.
But there are risks, right? Especially if you haven't replaced enough volume first.
Huge risks. You have to be really careful. For example, giving a potent vasoconstrictor like norepinephrine when the patient is still severely volume depleted, can actually worsen tissue perfusion in the periphery by clamping down vessels too hard. And using drugs that dilate coronary arteries, which might be good in cardiogenic shock, could actually drop the systemic pressure further in a hypovolemic patient, making the shock worse. Volume first, then S drugs if needed, and monitor closely.
Okay, that gives us a really solid picture of hypovolemic shock failure of perfusion due to lost volume. Now let's pivot to our second major priority concept, infection and the devastating systemic response we call sepsis and septic shock.
Right. And the definitions here are important. The Sepsis 3 consensus defines sepsis not just as infection, but as life-threatening organ dysfunction caused by a dysregulated host response to infection. Septic shock is then a subset of sepsis where the underlying circulatory and cellular metabolic abnormalities are profound enough to substantially increase mortality. We're talking persistent hypotension needing vasopressors despite fluid resuscitation and high lactate levels.
A dysregulated response.
Right.
So the body's own defenses go haywire.
Exactly. It starts with a local infection, maybe pneumonia, a UTI, a skin infection. But instead of staying local, the inflammatory response becomes systemic and overwhelming. This used to be called SIRS, Systemic Inflammatory Response Syndrome. This massive, uncontrolled inflammation triggers widespread vasodilation, increased capillary permeability, leaky vessels, and crucially, it activates the clotting cascade inappropriately throughout the microvasculature.
Microthrombi. Tiny clots forming everywhere.
Yes, tiny clots block blood flow in the smallest vessels, leading to widespread tissue hypoxia and cell damage, contributing to organ dysfunction. And at the same time, this rampant clotting uses up all the available platelets and clotting factors faster than the body, particularly the liver, can make more.
Which leads to DIC, disseminated intravascular coagulation.
Precisely. DIC is this paradoxical nightmare where the patient is simultaneously forming clots that block microcirculation. A&D is unable to form clots where needed, leading to a high risk of severe, uncontrolled bleeding. It's a hallmark of severe sepsis.
And this is where sepsis gets really tricky for assessment because early signs can be misleading, right? We often think of shock as cold, clammy, low BP, but early septic shock can look different.
Very different, potentially. There's often this initial hyperdynamic phase, especially in septic shock. Because of the widespread vasodilation and the heart trying to compensate for the falling systemic resistance, the cardiac output might actually be high initially. The heart rate is definitely rapid. But because the vessels are so dilated, the skin might feel warm and flushed, not cold and clammy. Blood pressure might even be normal or only slightly low initially. It can look deceptively okay.
So on the surface, they might seem relatively stable, warm skin, maybe okay BP, but underneath that leaky vasculature, the microclotting, it's causing massive tissue damage and setting the stage for collapse.
Exactly. That warm hyperdynamic state can mask the profound tissue hypoperfusion and the developing DIC. Eventually, if untreated, the state collapses. The heart can't keep up, cardiac output plummets, the vessels might remain dilated, but there's not enough volume to fill them, and then the patient looks like classic shock, cold, clammy, hypotensive, low CO. But by then, significant damage has often been done.
So early detection is absolutely paramount in sepsis. What tools do we have? The sources mention screening tools.
Yes, given how subtle or misleading the early signs can be, standardized screening is key. The QS-OFA, or Quick Sequential Organ Failure Assessment, is highlighted for use outside the ICU. It's simple and quick.
What does QS-OFA look at?
Just 3 things, easily assessed at the bedside. 1 point if the systolic blood pressure is 100 millimeter Hg or less, 1 point if the respiratory rate is 22 breaths per minute or higher, and 1 point for any change in mental status from baseline.
And if the score is?
A score of 2 or 3 on QS-OFA is considered positive. It doesn't diagnose sepsis, but it strongly suggests the patient is at high risk and needs immediate further assessment for organ dysfunction, like checking lactate levels, renal function, liver function, etc.
Okay, and there's also MUWS.
Right, the MUWS, or Modified Early Warning Score. It's often used alongside or incorporates elements of QS-OFA, but usually adds in heart rate and temperature measurements to give a broader picture of potential clinical deterioration. Different institutions might use slightly different versions.
The key takeaway is, use a validated screening tool consistently.
Absolutely. Don't rely on gut feeling alone, especially early on.
Okay, so let's say sepsis or septic shock is identified or strongly suspected. The clock starts ticking immediately. Our sources emphasize the Hour 1 bundle. This isn't just a guideline, it's a standard of care. 5 critical interventions within 60 minutes.
Yes, treating sepsis is a time-critical medical emergency just like stroke or MI. The bundle elements need to happen concurrently and rapidly.
Let's list them. Number 1,
Measure lactate level. And critically, if that initial lactate is elevated, usually above 2 millimole, you need to remeasure it within a few hours to see if your interventions are working. High lactate equals significant tissue hypoperfusion.
Okay, number 2.
Obtain blood cultures. Absolutely essential to identify the specific organism causing the infection if possible. And crucially, this must be done before starting antibiotics.
Which leads to number 3.
Administer broad-spectrum antibiotics. Get them in quickly. You start broad to cover the most likely pathogens, and then you can tailor or narrow the therapy later once culture results are back. Don't delay antibiotics waiting for cultures if getting the cultures will cause a significant delay, but ideally, cultures first.
Right. Number 4. Fluids.
Yes. Rapid administration of 30 millimolars per kilogram of crystalloid fluid, like NS or LR. This is specifically for patients who are hypotensive, MAP 65 or SBP 90, or have a lactate level of 4 millimolar or higher, indicating severe hypoperfusion. Bolus it in quickly.
And number 5, if fluids aren't enough.
Apply vasopressors. If the patient remains hypotensive, MAP still below 65 mm Hg, despite that initial fluid bolus, start vasopressors. Typically, norepinephrine is the first choice to constrict the blood vessels and bring the pressure up.
That 1-hour window for all 5, it's non-negotiable for improving survival chances.
Absolutely non-negotiable.
What about other therapies mentioned for sepsis? Antibiotics obviously continue.
Yes, often using multiple antibiotics initially until sensitivities are known. Another key area is glucose control. Sepsis often causes hyperglycemia due to stress response and insulin resistance. We need to manage that, typically with insulin infusions, but the target range is usually moderate, something like 140 to 180 milli-GDL. Trying to achieve super tight control, like below 110, has actually been shown to increase mortality risk due to hypoglycemia. So control it, but don't overdo it.
Okay. And anticoagulation, with all that microclotting.
Yes, low-dose heparin or low molecular weight heparin is often used to try and limit that microvascular thrombosis, unless the patient has DIC with severe bleeding already.
And blood products, if DIC is causing bleeding.
Then yes, replacing clotting factors and platelets is crucial. The text specifically mentions that platelet transfusion is often recommended ahead of other blood products if bleeding occurs in the context of DIC and thrombocytopenia, as replacing platelets can sometimes help stabilize the situation.
Okay, that's a lot to process for both hypovolemic shock and sepsis. Let's try to bring it together. So, what does this all mean for you, the learner, trying to grasp this really high-stakes area of nursing?
Well, we've looked at two really different paths to shock, one driven by pure volume loss, the other by a haywire response to infection. But fundamentally, they both converge on that central problem, perfusion failure at the cellular level. Maybe the biggest takeaway is to stop looking at vital signs as single isolated numbers. You absolutely must monitor trends over time.
That feels like the most critical assessment piece. Recognizing those subtle early cues we talked about, that slight persistent uptick in heart rate, the small increase in respiratory rate, maybe the urine output just starting to dip below that 30 milliliter mark, those are the alarms going off in the compensatory stage, when things are still fixable relatively easily. If you ignore those, you risk sliding into the progressive stage,
Where that 1 hour clock starts ticking for definitive intervention, like the hour 1 bundle for sepsis. Missing that window dramatically increases the risk of MODS and death.
And maybe a final thought, connecting back to the patient's experience.
Yes, I think it's really important to circle back to those subjective cues. The restlessness, the anxiety, that profound feeling of impending doom that patients sometimes describe. We need to really internalize that these aren't just emotional reactions much of the time. They are often direct physiological manifestations of the body compensating, or of early cerebral hypoxia. When you start seeing those behaviors as potential objective data points, as critical warning signs from the body itself, it truly elevates your nursing assessment and prompts a faster, more effective response. It's understanding the why behind the feeling.
That's a really powerful point to end on. Understanding the physiology behind the patient's subjective experience. Thank you so much for walking us through this, and thank you for tuning in and engaging with this deep dive into the critical care of shock. We genuinely hope this breakdown helps you approach this complex and vital topic with more clarity and confidence.
Absolutely. Until next time, stay informed, stay vigilant, and keep a close eye on those trends.